is 3 weeks now post-op removal of a pheochromocytoma and developed a deep iliofemoral thrombophlebitis, and she's being heparinized now. She's been on heparin approximately 5 days.
The multidisciplinary approach is a well-accepted technique in modern medicine. The combined skills of the internist, the surgeon, the radiologist, the endocrinologist, and a host of other specialists provide medical treatment that focuses on the total care of the individual patient. Today, another specialist is being recognized as an important part of the multidisciplinary group. At a time when drug therapy is becoming more and more complicated, and at the same time more important, effective medical treatment cannot be accomplished unless the clinically trained pharmacist is an active member of the hospital medical team. Health Sciences Television Network of the University of California, San Francisco Medical Center presents This Moment in Medicine, a series of programs devoted to the practical application of modern health science information and techniques in today's clinical medicine. This program on clinical pharmacy, a new concept in patient care, was produced with the cooperation of the School of Pharmacy at the UC Medical Center in San Francisco. Our participants from the Medical Center include Dr. Joseph L. Hirschman, lecturer in pharmacy, School of Pharmacy, and supervisor of the Drug Information Center. Dr. Donald W. Holston, clinical instructor, School of Pharmacy. Dr. Robert A. Miller, assistant clinical professor and coordinator of the Pharmacy Pilot Program and Drug Information Center. And Dr. Don Carlos Hines, lecturer, Departments of Medicine and Pharmacology.
We're all familiar with the fact that physicians are properly reluctant to discuss any patient clinical data with anyone not a member of the medical team. As it stands today, too few pharmacists are members of the medical team. Most pharmacists have been drug-oriented to the exclusion of patients as persons and the complexity of patient care. This then means the pharmacist is unfamiliar with the actual clinical procedures that are used to diagnose, evaluate, and treat the individual patient, such as laboratory testing, EKG evaluation, radiology, biopsies, all the many others. So here we have a pharmacist with expertise on drug potencies and possible side effects as far as the drug literature goes, but without the experience of clinical use and manifestations on the individual patient. It is our belief that pharmaceutical advances cannot be put to the best clinical use until the pharmacist becomes an active member of the medical team. This has been our goal in the 2-year pilot program you are going to see and hear about. It was conducted under actual hospital conditions at the San Francisco Medical Center. Now, before we go any further, let's consider the basic question of the whole concept. Why should a clinical pharmacist be involved in patient care? What can he add to the team care of a hospitalized patient? Dr. Miller, would you answer this?
I think we all realize that hospitals are taking care of increasing numbers of patients each year. We also realize that the number of drugs becoming available to the medical teams are also increasing. But simultaneously with this increase, the complexity of each of these individual drugs is also increasing. Dr. Hines, I wonder if you have something to say on this.
The practice of medicine and training for medicine are becoming more complicated all the time. Drugs are used more often, there are more of them, and their effects are increasingly complex. In addition, there is really less time available to learn about them.
Now, the pharmacist, who certainly spends the majority of his time learning about these drugs and realizing some of the minor differences between them, unfortunately is not in the best area to utilize this knowledge. This is because he is detached from the patient and the area of patient care. An example here is this group of primarily glucocorticoids. And we can see here the tremendous range and difference between the approximate equivalent dose of, let's say, cortisone as compared with betamethasone. But another thing that's very important to note is the fact that for each one of these preparations, the great number of commercial preparations or drug products that are available for the physician from which to choose. Now, each of these different products While the differences may be clinically insignificant and very subtle, nevertheless, under certain conditions, these differences are very critical, especially to the patient. These are differences in rates of absorption, rates of excretion, half-life, and preferential routes of administration. All these little differences can make a very large difference, clinically speaking. This problem does not limit itself strictly to physicians. Nurses are also faced with the problem of increasing complexity of drugs and drug products. In a recent study at the University of California Medical Center, it was determined that greater than 20% of the nurse's time was spent in procuring, preparing, administering, and charting of medications. When we realize that the combination of the increased complexity of the individual drugs plus the lack of efficiency of many of the drug distribution systems now being practiced in hospitals, both come to bear upon the nurse, we realize that there is a primary problem in medication error. Dr. Hirschman, what about all this?
The question of medication errors is much more widespread than might be imagined. Several investigators have studied the problem. The classical study in this area was one done at the University of Florida Medical Center in 1962 by Barker and McConnell. They found that 1 out of every 6 doses administered was in one way or another an error. These errors included omission, underdosage, overdosage, extra dose, unordered drug, wrong dosage form, and a drug administered at the wrong time. However, this study does not include the problem of adverse drug reactions or the use of any inappropriate or ineffective drugs. Several studies have been done to delineate the problem of adverse drug reactions. The first study, done in 1965 at the Montreal General Hospital, involved 731 patients over a period of 12 months. 132 of these patients experienced a total of 193 adverse drug reactions. 48 of these were prior to admission to the hospital, and 145 were after admission to the hospital. 17 of the 67 deaths on the service were the result of an adverse drug reaction. At Johns Hopkins Hospital, a similar study in 1966 involving 714 patients resulted in a total of 122 drug reactions. There were 8 deaths from adverse drug reactions on this study. In the Johns Hopkins study, the average hospital stay for a drug reaction was 20.8 days, but it was only 14.3 days for all patients on the medical wards. An example of an adverse drug reaction that we have seen at the UC Hospital was a situation where a patient in partial renal failure was given kanamycin in the standard dose. This would have been all right for a normal patient, but in this case it caused irreversible deafness. Based on our experience using a clinical pharmacist on the floors, working closely with physicians and patients, we are convinced that many errors of these types and adverse drug reactions can be avoided, or at least their effects reversed earlier. But although avoiding errors is important, it's even more important that the most effective drug be given in the first place, and its use monitored by trained specialists in drugs.
Well, all right, what's the job? It's obvious that we have to make an explicit effort to bring together the clinician's medical knowledge of patients and all the available pharmaceutical data that can affect the patient's recovery. We have to try not only to avoid errors, but to make the therapy as beneficial as possible. And one way of working toward this goal involves the direct participation of the clinical pharmacist in health care, beginning with the admission of the patient.
Hello, Mr. Day. I'm Dr. Robert Miller, one of the pharmacists assigned to this unit.
Hello.
I'll be involved in the drug therapy that we'll be getting, and I wonder if I could take a little bit of your time to find out something about medications you've been on in the past.
Sure, go ahead.
Now, what we're interested in primarily is not only the medications that have been prescribed by your physician at home, but also any medications you've been able to buy in a community pharmacy. Mm-hmm. Primarily, have you been on any drugs within 1 month prior to being admitted to the hospital?
Yes, I take Librium.
Librium?
Librium, yes. I take that 3 times a day usually.
And how do you know this is a Librium?
Oh, it's on the prescription label.
I see. And how often did you say you take that?
3 times a day.
I see. Are you taking anything else?
Not
this last month?
steadily. I occasionally, can't sleep at night and the doctor has prescribed Benadryl. I take one of those usually.
I see. Anything else?
No, nothing I can think of offhand.
I noticed that upon admission, you were complaining about a fairly deep chest pain. Were you taking anything for this?
Yeah, well, yeah, I did. I took a capsule. I don't know what it is. It's a small pink capsule. It's for pain. I got it about 2 months ago. I'd completely forgotten about it. I took it about 3 hours ago.
I see. How often do you take this?
Well, I usually take it as needed, every 4 hours, but it's not something I take all the time.
I see. And this was prescribed by your physician at home?
Yes.
That was Dr. Johnson?
Dr. Johnson, yes.
I see. All right. Are there any other medications that you can think of that you've been taking?
None I can think of offhand.
I see. Have you ever had any type of an adverse reaction to a drug?
Oh, I'm sorry to stop you for a second. Yes, I occasionally take Dristan.
Tristan.
It's a product that gives me some relief when I have a cold and so on.
I see. And how often do you take this?
Well, I had a cold about 2 weeks ago, and I was taking them about 4 times a day
4 times a day. For how long?
for about 2 weeks.
I see. All right, fine. To get back to any type of an adverse reaction, have you ever experienced an adverse reaction or
I don't know.
toxicity to a drug
What?
that you can think of?
An adverse reaction?
Have you ever taken a drug and got a not the usual effect from a drug?
Yeah, well, the only one I can think of, and it's one that really sticks out, is penicillin. I took it one time, and I had a bad reaction to it
Penicillin. How long ago was this?
about 4 or 5 months ago.
I see. And were you given this orally, a tablet, or was this an injection?
It was a capsule.
I see. And what was the nature of the reaction? What happened?
It upset my stomach. I just didn't feel good.
It upset your stomach. Were you treated by your physician for this?
No,
The upset stomach?
I didn't even tell him about it. I just kept taking it, and it went away.
I see. And you did keep taking it?
Yes.
It went away. All right, fine. Have you ever had any other types of problems like that?
Well, occasionally the Benadryl I take makes me drowsy. That's supposed to do that.
Right.
Is that an adverse reaction?
No, that's normal reaction to the drug. Have you ever had any other antibiotics with the exception of penicillin that you can think of?
No, I don't think so.
I see. Have you ever had narcotics before?
Yes.
Which narcotics?
Well, one of them was a codeine preparation. I don't know what. It had codeine in it, I know. And then I one time took a yellow tablet. I knew it was a narcotic, but I don't know the name of the product. It was about the same size as an aspirin tablet, maybe a little bigger.
This was at home or in the...
It was after a dental procedure. I had a tooth yanked. And
I see. All right. Have you ever had a blood transfusion?
no, I've given blood, but I've never received it.
All right. What about foods, Mr. Day? Have you ever had a reaction to any food, any type of an allergy to a food?
None that I can think of. No, I'm sure I haven't.
Do you take any...
Occasional upset stomach, but that's about it.
I see. Do you take any foods excessively? Special types of foods or different types of foods?
Yeah. It's a funny thing you should raise that. I'm sort of hung up on licorice sticks.
Licorice?
Licorice sticks. I have to eat about 10 of them a day.
Now, this information, as you've seen, that the clinical pharmacist obtains from the patient at admission, information, incidentally, that may be essential to his recovery, remains a part of the patient's history throughout the period of hospitalization. This initial phase of the clinical pharmacist's involvement in patient care, this procedure has been used in our pilot program covering approximately 80 beds in the Moffitt Hospital at the San Francisco Medical Center. The information obtained in the interview is recorded, as you saw, on a form, and we shall call this form, or we call this form, the Patient Clinical Status Drug Profile Form, or PCDP for short. Now, this form has an admitting diagnosis, the age, the race, the personal history or the patient history that he presents with. It also shows a vital signs sheet with the drugs that the patient is currently taking, his weight, his in and out sheet. It also contains items such as all of the chemistries, the blood tests, urinalysis, and this type of thing that normally go into the routine treatment of a patient. And also notes on specialized tests that may have been ordered, biopsy results as example, or the EKG results, radiological data, and this type of thing that the patient undergoes as a guest of the hospital. Now, the information is recorded, as we said, on this form. What's the point behind the interview? Well, it's probably already clear, but it might be helpful to state the object explicitly. 1, recognize and prevent adverse reactions. 2, eliminate the interference between drugs and clinical tests. And this is an area which we're expanding on markedly, and the literature will be expanding on this markedly as the time goes on. Monitor the progress of drug therapy. Well, this is what we're doing here, or what we're saying here, is that we want to monitor the vital signs and the progress notes as a particular facet of drugs in the patient. 4, use the information in consultation with physicians. And 5, give the clinical pharmacist exposure to the patient. Now, as an example, say, for the first item on the chart, recognize and prevent adverse drug reactions, we had a patient on the floor on cephalosporin. Given intramuscularly, the maximum recommended dose was given 4 grams a day. Patient also was on another potentially nephrotoxic drug. The clinical pharmacist followed the lab test on this patient and spotted the urinalysis report showing showing casts and protein in the urine. Now, this is the earliest sign of potential toxicity attributable to drug and associated with renal damage. Now, the significance of this situation was pointed out to the physician by the clinical pharmacist. A change of drug was ordered, and a possible adverse reaction was avoided. These examples, indeed, can be rather dramatic. Now, the patient interview is just the first way the clinical pharmacist gets started with the involvement in patient care. In our program at the University of California Medical Center, he remains part of the hospital medical team throughout the patient's stay in the hospital. And he does this in a regular way, on regular teaching rounds, on ward rounds, and consultations with the physician. But let's state here clearly that the physician is still in charge of his patient. He's still fully responsible for his patient. The clinical pharmacist functions as another member of the patient care team.
Good morning. How are you feeling today?
Well, not too good today.
How did your illness start?
Well, I've been having the trouble with my colon for some years, but a few days ago I developed trouble with urination. Then I developed a fever.
Doctor, what do you have to say about this?
Well, for some time this girl has had chronic ulcerative colitis, for which she's been receiving steroids. And just recently now she's developed this acute upper urinary infection, and this is why she's here today.
Have you decided on treatment yet?
Well, I've thought about antibiotics.
Have you made a choice?
Not yet.
Well, perhaps we'd better go where we can discuss this. We'll be seeing you again.
Thank you.
Doctor, tell us something more about the infection.
We cultured the infection and found that it was only E. coli.
Now, have you made a choice of antibiotic?
I'd thought of tetracyclines.
You're our specialist in drugs. What do you think of that?
Well, the tetracyclines would certainly work against E. coli, but in this patient, she's been on steroids for long term, and her host defenses have probably been suppressed by this, and tetracycline is a bacteriostatic drug, so I think really a bactericidal drug should be used in this situation.
What do you think of that idea?
That certainly sounds reasonable.
Have you any suggestion as to specific drugs?
Yes, either cephalofen or ampicillin could be used in this situation. They are both bactericidal, not bacteriostatic.
This is very reasonable, isn't it?
It certainly is.
Now, so far we've seen how the pilot program, our pilot program, works with the clinical pharmacist assisting in the selection and monitoring of drugs for patients on the floor. But before we discuss the role of the clinical pharmacist further, I think it would be helpful to explain the system of distribution we use. This is what we call a unit dose system. It involves 3 basic documents and a 6-step process. This chart here delineates these steps. Step number 1, the physician order goes to the pharmacist. And what we use in the hospital is the NCR duplicating paper. And this duplicates the chart order as it's written and allows the pharmacy to have a complete copy of the full orders written for each patient every day. Step 2, the pharmacist assesses and interprets the order. Well, he transcribes these onto a 3-part control form. This is almost redundant. The pharmacist assesses. He takes a look to see whether the order that he receives is a valid order, a good order, whether or not it involves drug. And then he interprets the order. He transcribes it onto this 3-part system, this 3-part control card, so that the technician then can take over and do his part of the, which takes us into step 3. Step 3, the technician processes the order and provides the patient supply. Here we use a pharmaceutical technician trained to fill the order as we process it on the card. He then can take the order, transfer the drug from a stock container into the patient's own medication drawer, and provide this type of service. Step 4, the pharmacist verifies the technician process, and of course this is the essential check and double check feature. The pharmacist will then check all of the doses prepared by the technician for the patients on the floor. Step 5, the patient's medication is resupplied at 8 a.m. and 4 p.m. Now in our hospital, we found that our orders can be, or we can resupply these medication charts twice a day as a routine, although orders written during the day are naturally supplied to the patient's drawer. But we only have to change them by and large twice a day. Step 6, the nurse gives medications, checking with the PSR. This PSR document is, what it really is a nursing cardex expanded only to drugs, and provides a complete record of exactly what the patient has taken over as long as a 7 or 8 day period. Now, the next part to go into is the IV control form. The IV control is, as you can see, is a similar document to the PSR in that it controls all of the intravenous bottles and infusions of mixtures and the additives to these intravenous infusions during the course of the patient's stay. And again, this can be monitored for a period of 7 or 8 days. And again, this can reflect what the patient is doing clinically as regards his electrolytes, his blood data, and this type of thing. Now, a 6th step, many formed, set up for distribution may at first seem cumbersome and redundant. But we find and we feel that this is the essential part of our unit of use system, because this provides the check and double check and even triple check from drug to patient. Now, while we think this system is desirable, like any formal organizational device, its real utility depends in part on those who use it and how it's used. Dr. Miller, would you comment on how the unit of use program fits into our pilot project?
There's no question that the system is working with many advantages, such as the patient getting the correct dose and getting this dose on time. The nurse is able to keep a more accurate track of the medication regimen using the PSR. The nurse is also presented with the medication she needs, pre-labeled, and therefore this medication is totally identifiable right to the time of administration. And of course, there is an economic saving to the patient, not having to be billed for unused drugs. Therefore, medication crediting is almost a thing of the past with this system. But as desirable as the unit dose system is, and certainly we agree that it's better for a hospital to have it than not, by itself, it will not represent a qualitative change in the monitored drug therapy for the hospitalized patient. They still need a clinical pharmacist on the floor, working closely with the physician to continually monitor and assess the progress of the patient on a given regimen. The unit dose system by itself, without a clinical involvement of the pharmacist, might get the patient the correct dose and get this dose to them on time. But the system by itself does not give the physician the additional information he needs to use the drugs with the greatest possible effectiveness. For example, the physician has to know about physical incompatibilities between drugs. If the unit dose for a patient is filled by a pharmacist who doesn't know about the other tests being run on a patient and/or other drugs the patient is taking, the latter would not have the systematic knowledge about the patient's sensitivities. Therefore, the system by itself wouldn't tell the physician he might have ordered the wrong drug or perhaps a less efficient drug for the particular symptomatology. The system, therefore, will still need a pharmacoclinical interpretation, which works best when there is a close working relationship between the physician and the clinical pharmacist.
Dr. Hirschman, a patient has come to me who was recently moved here from another city, and she told me that her physician there told her that her aching bones were due to antacids. Now, she's been taking antacids for quite a long time because she has a chronic peptic ulcer. What do you know about this?
Yeah, I think this is a possibility. I recently read a study in the New England Journal of Medicine on this problem. Antacids presumably are relatively innocuous drugs, and however lately there's been quite an intense interest in reevaluating these products, and one of the problems that's come along is the interference of the absorption of dietary phosphorus with the so-called non-absorbable antacids such as magnesium hydroxide and aluminum hydroxide, particularly when they're used over long periods of time on a chronic basis. It's quite conceivable that your patient could have aching bones from taking these antacids, and the mechanism of this seems to be the interference of absorption results in a mobilization of calcium phosphate from the bones, which could give the aching bones, particularly if she walks or is active on them, on her limbs and things like this. Also, the depletion of serum phosphorus could lead to weakness, malaise, and anorexia as well further along in this syndrome.
No, I understand from what you've told me now that there are just certain antacids that do this, that calcium carbonate, for instance, might not. Is that correct?
Yeah, that's correct. Probably the divalent, trivalent hydroxides like the aluminum and magnesium hydroxides seem to be the ones that do this. There's only been this one study so far, and they used these two, evaluated the antacid products that contain these two, the aluminum hydroxide and the magnesium hydroxide. So we really can't say yet whether all of them do it or not.
Well, how could we find out if this is really the cause of her aching bones?
As I recall from the study, there are some laboratory tests that could be run, but I'm a little hazy on what they were. Maybe I better check with the Drug Information Center.
Now, this is an actual shot of the pharmacy on the 9th floor of the Moffitt Hospital. This is one of the staff, and what he's doing now is looking essentially at a visible drug cardex, or drug file. This gives the current information on listing of most of the drugs used in the hospital. His answer was not apparent to whatever question he may have had, so he writes the DIC. This is one of the men in the DIC. This is an electrowriter. Transfers the written message through telephone lines. The question is being written on this electrowriter from the 9th floor. This is, again, the DIC. He's receiving this question at this time. Now, his next process is going to be to evaluate the question, make sure that he has a good, solid question, something that he can look up, something that it is pertinent to him. Now he goes to check the references that he has right available to him in the DIC itself. Now, you must remember this DIC is in the library, so he has the total influences of the library to go back to. Now we're back on the floor again. Here the pharmacist is consulting. Now we're back to the DIC. The question is about to be answered, and the pharmacist there can write the answer to the question directly on the floor. Now, the information that you saw being transmitted to the floor via the electrowriter can be supplemented later with a drug information report form, this hard copy. This system is not really expensive. It doesn't involve a large capital expenditure, and since the clinical pharmacist is always on the floor, like the physician, the Drug Information Center doesn't have to be physically manned at all times. Because the system can take requests and record them 24 hours a day, either from inside the hospital or from outside the hospital. Here you see the recording device being utilized. We can try to anticipate the potential error and utilize a recording device to monitor our telephone service. This is what you're looking at now.
Blacked out, supposedly fell to the floor. Now,
We've covered most of the basic features of the pilot program thus far, but we haven't hit on the big word or the big subject, evaluation. Does it work? Want to speak to that?
Well, we're convinced that unquestionably it does work, but that doesn't prove anything by itself. The important thing is that the project would not have lasted 2 years unless the physicians and nurses in the pilot program found it useful, and we think unquestionably they have. But I would like to respond to the question another way, anecdotally. This isn't quantitative, but sometimes actual incidents give truer insight into a situation than statistics. Dr. Hirschman?
Yes, I recall when we first started up on the floor with our project, a patient was admitted from another hospital following a spontaneous abortion with developing peritonitis. She had been on tetracycline and chloramphenicol intravenously for several days, but without any clinical results. When she was admitted to our floor, we pointed out that these two antibiotics are incompatible in the same intravenous solution, but it's not a visible reaction. We suggested to her physician that if one of the antibiotics was given intravenously and the other intramuscularly, they could avoid this incompatibility. This was done, and the patient became afebrile within 30 hours.
Another time a patient was admitted for elective surgery. The clinical pharmacist during interview found the patient to be allergic to aspirin. Postoperatively, a house staff officer wrote an order for Percodan. Percodan, of course, contains approximately 300 milligrams of aspirin per tablet. This information was given to the house officer, and the medication order was stopped, and a new drug was inserted in its place, and a potential adverse drug reaction was prevented. Another time, a physician ordered Procaine penicillin, when upon interview we were able to determine that the patient was unquestionably allergic to Novocaine, Novocaine being the trademark for Procaine. Again, this information was passed to the medical staff, and they were able to change the order.
Well, let's give Dr. Hine a chance now to talk about some of his experience.
One of our patients had an acute psychotic episode in the course of total renal failure. We asked the Drug Information Center about an antipsychotic drug that would be neither metabolized nor excreted by the kidney. They suggested chlorpromazine, which we used with no problem.
One time when I was working down in the Drug Information Center, one of the residents on the vascular surgery team wanted to know about interactions between nortriptyline, an antidepressant, and chlordiazepoxide, a mild tranquilizer. The patient had been experiencing some ataxia, and he wanted to know if this could occur using under a combination of these two drugs. We looked into this, and we found that this could result, and we told the physician, and one of the drugs was changed, and ataxia disappeared. In another situation in the Drug Information Center, a physician in private practice wanted to know how long postural hypotension would last after a combination of chlordiazepoxide and Nardil, a monoamine oxidase inhibitor. We told him that orthostatic hypotension can result from monoamine oxidase inhibitors, but if it lasts longer than a week after discontinuance of the drug, he should probably look for some other cause. These anecdotes show in specific clinical instances the practical value of having a pharmacist available on the floor personally and backed up by the Drug Information Center to help clinicians improve drug therapy on the ward and in the community as well.
Well, now, we've certainly talked and rather extensively covered the field of drugs, and these certainly are interesting and rather dramatic aspects of pharmacists on the floor. But are there any other aspects that of this pilot program that you think can illustrate the utility of having a pharmacist in a working relationship with the physicians on the floor?
Well, certainly one aspect that comes to mind immediately is our participation as part of the cardiopulmonary resuscitation, or Code Blue team at the University of California. This four-man team consisting of residents in cardiology, thoracic surgery, anesthesiology, and the clinical pharmacists from the pilot project respond to all cardiac and pulmonary arrests within the hospital. It's the clinical pharmacist's primary responsibility on one of these emergencies to prepare and record all the medication being utilized during that emergency and to provide any information that the physicians might want during such an emergency. Another thing here, it's of quite a bit of interest, is this recent study by the United States Public Health Service, who are able to estimate that over 1.3 million adverse drug reactions occurred annually within the United States. And if we look at the economics of these adverse drug reactions and look at the direct costs, which would include the extra amount of time of keeping the patients in the hospital, the extra medication needed to take care of the adverse reaction, the extra studies or the additional studies, the additional procedures being done, they've been able to estimate, and conservatively so, that the cost of this would be over $50 million per year directly attributable to adverse drug reactions.
Well, I think we've shown that this approach to drug therapy, using the clinical pharmacist on the floor, does have a real merit. But of course, we believe in it because we've all been involved. What we also recognize is that there are problems, and problems that have to be solved. For example, how is it possible to affect the pharmacist's strong orientation to drugs?
Well, that point is essential to the entire approach. You know as well as the rest of us that it can be done, but it takes time, effort, motivation, and most of all, commitment. In order to find out about patients and how they're taken care of, you have to be around patients and the people who help them. And you'll have to find out something about this help, at least to permit the pharmacist to do his job more effectively. Some of this can be learned from physicians on rounds, at medical conferences, and so forth, by listening carefully and trying to understand as much as you can about the medical side of patient care. Now, this certainly doesn't mean trying to become a physician in your spare time. It only seems logical that for a pharmacist to provide drug information to a physician that will be of maximum use to the physician, the pharmacist should try to learn as much as he can about what happens to the patient before and after he takes the drugs that the pharmacist may have had something to do in suggesting to the physician. But even in more practical terms, pharmacists can go to the various clinical departments to learn more about the medical procedures that are being used in the clinical situations. That's precisely what our pharmacists in the pilot program did. What you're seeing here is one of the clinical pharmacists visiting the clinical laboratories. Here, a clinical pathologist, I think specifically here he's in clinical microscopy, showing one of the auto-analyzer pieces of equipment and explaining the operation of this equipment to him. You can see the importance of going through these various laboratories so that a truer understanding of what the tests are for and how they are run. It makes it very difficult once you see the results of these tests in the patient's chart on the floor if you don't have an understanding as to how the test is actually being run and the reason for running the specific test. This, of course, gives us a better insight into how drugs can also interfere with these tests by posing these types of questions to the personnel in these laboratories. Here, the clinical pharmacist is visiting Department of Radiology, where a technician is showing some of the various pieces of equipment used to take ups in reading of X-ray pictures, so that when we see these things on rounds, it will make more sense to the pharmacist. Here he's going into our intensive care unit. Here he will learn to see the various types of specialized equipment that's available to him and to see the types of patients that are kept in this unit. In addition to what you've seen on film, the clinical pharmacist has become a familiar face in the surgery suites at the University of California. Here he observes the surgeons and the anesthesiologist as they go through various procedures so he can have a better insight into the condition and the procedures used on the patient before they come back to the floor. Also, he will attend conferences at the electrocardiography department where technicians will show him how to operate the equipment and exactly what some of the EKG equipment can and cannot do. Now, we are not saying that this is the complete answer to orienting the clinical pharmacist to patients and to increase his contribution that have to be worked out. An example of this is how to bring local hospitals and hospitals that have lesser number of beds than a university teaching hospital, how to bring these types of hospitals into this particular type of program and the retraining of their pharmacists so they want to participate in this type of a program. In addition, the schools of pharmacy will have to readjust their curriculums so that in addition to the traditional training of the pharmacist so that he is drug-oriented, now they bring into play the patient or clinical orientation so that each student gets a more general outlook and so that he can more appreciate how drugs are utilized on patients.
We have tried to illustrate a new approach to drug therapy on the hospital ward. The addition of the clinical pharmacist to a member of the medical team can enhance the actual patient care. Based on our experience here in the hospital, we're convinced that a properly trained pharmacist can make a significant contribution on the medical team and can be an active participant in patient health care. Now, this is not accomplished by being stationed on the floor 24 hours a day or merely passively making ward rounds, but by properly motivated active contribution. If the team concept in patient care is to become significant, every member of the team must freely commit his full resources, and the judgment of each of these individual specialists on the team must be employed fully and completely. This then keeps the clinical pharmacist active because his knowledge and the team concept of comprehensive care require that a patient's preparation for the return home be as thorough as the admission. Here the cycle of the pharmacist participating in patient care comes full turn with the discharge interview.
Mr. Kimball, how are you?
Pretty good.
All set to go home?
I sure am.
Good. I have your medications for you that you're to take when you get home.
Okay.
These tablets are an antibiotic to prevent any recurrence of your infection. You're to take these 4 times a day, 1 tablet 4 times a day. Now, ideally, if you can take these every 6 hours, you'd get the maximum benefit from them.
Well, is there any problem with taking these now? In my job, I do a lot of driving. Is there any problem with drowsiness?
No, these won't bother you as far as drowsiness goes, but there is one thing, that you should take them on an empty stomach if you can. This would mean 1 hour before meals or 2 hours after meals to get the maximum effect from these drugs. Okay, you can have
Well,
that.
about how long do I have to take them?
You should take these until you use them up, and you'll have enough until you get back to clinic next week, and your physician will tell you whether you should continue on them or not at that time.
Okay, fine.
Yeah, also, I have this antacid for you that you should take to prevent any recurrence of your ulcer, and you should take this about a tablespoonful after meals and at bedtime. Now, there's one important point here that when you take your bedtime dose, try to avoid taking it at the same time as your antibiotic, because this may interfere with the effectiveness of your antibiotic also. So you can take this.
Okay. I have one question. I generally enjoy a martini before dinner. Is there any problem with taking these at the same time? Or?
Well, there's no problem with taking it at the same time, but alcohol may aggravate your ulcer, and this is why you're taking this medicine. So I would avoid it. And I would
avoid the martini.
Yes, and I'd talk to your physician about this. Also, if you run out of this before you get back to the clinic, you can buy this in a pharmacy without a prescription.
Oh,
this is just to get you started.
Real good. This one I have to.
That's right.